Hey, welcome! Today we're diving into something truly fascinating, how doctors actually figure out what's wrong. And let me tell you, it's not just about checking boxes off a list. It's more like high-stakes detective work, where every single clue could be the key that unlocks the entire mystery. So, let's dive in.
So that's the big question, right? When a patient walks in with a whole mess of symptoms, how does a doctor cut through all that noise to find the real answer? It's this incredible process of listening, digging for clues, and connecting dots that, honestly, might not seem connected at all.
And here's the fun part. You're not just watching from the sidelines today. Nope, you're going to be the detective right alongside me. We're going to tackle two real-life medical puzzles, step by step, using the exact same clues the doctors had. So, you ready? Let's see if we can crack these cases.
Okay, first up we have case file number 1. I'm calling this one the protein puzzle, and as you're about to see, a very strange, misbehaving protein is at the absolute heart of this entire mystery. So, let's meet our patient. She's a 52-year-old woman, and she's here because, well, she just knows something's off. It's not one big thing, but a whole list of concerns that's been growing for the last 6 months.
Okay, so just look at this list of clues. It's kind of all over the place, right? You've got general stuff like feeling tired and losing weight. Then there's really specific physical signs like the swollen legs and even an enlarged tongue. And then these functional clues, getting dizzy when she stands up and seeing frothy urine. Every single one of these is a piece of the puzzle.
The patient's story is one thing. Now we need cold, hard facts, and that means lab work. These results, wow, they tell a huge story. Her hemoglobin's a bit low, which explains the fatigue, but the real story here is the protein. Her albumin level is way down, and her urine is packed with protein. That's like a giant flashing neon sign pointing straight at her kidneys. They're leaking protein like a sieve.
So, with the kidneys as our prime suspect, the doctors take a closer look with a special biopsy. And boom, this is the moment, the smoking gun. A specific stain called Congo red literally lights up under the microscope, showing these weird, abnormal protein deposits. We finally have a name for our culprit, amyloid.
So, what in the world is this stuff? Well, amyloidosis is a pretty rare disease where the body starts making these faulty, misfolded proteins that just clump together. That analogy on the screen is perfect. It's literally like sticky protein gunk, just jamming up the gears of the body's most important machines: the kidneys, the heart, the nerves. That's what's been causing all of her symptoms.
Okay, so we've got our bad guy. Case closed, right? Well, not so fast. Finding the culprit is only half the battle. Now comes the next big puzzle, figuring out the right way to treat it. And this is just as important as getting the diagnosis in the first place. Now, her kidneys are failing, right? So your first thought might be, hey, let's just do dialysis. But think about it. That's just treating a symptom. It's like constantly mopping a flooded floor, but never ever turning off the broken faucet. It doesn't stop the problem at its source.
All right, what about something more heavy-duty, like a stem cell transplant? I mean, that's a powerful treatment for sure, but it's way too much for a first step. That's like trying to rebuild a house while it's still on fire. It just doesn't work. You got to put out the fire first.
And that, right there, leads us to the real answer. You have to go after the source. The problem is the type of cell that's gone rogue, just churning out this bad amyloid protein. So, the correct approach is chemotherapy, designed to shut down that faulty protein factory for good. Stop the production, you stop the damage. And just like that, Case 1 solved.
All right, detective, you did great on that one. Ready for round 2? Our second case file is a completely different kind of mystery. I'm calling this one the missing ingredient.
So meet patient number 2. She's 34, and her main complaint is something a lot of us can probably relate to, at least a little bit. She is just completely, totally drained of all her energy.
So her story starts with fatigue and getting short of breath, which are classic signs that oxygen isn't getting where it needs to go. But then you get these really specific, almost textbook clues: brittle nails, thinning hair, and this one, spoon-shaped nails. Weird, right? But super important. You combine that with a history of heavy periods, and a very clear picture starts to form.
And wow, if we had any doubts, the lab work just blows them out of the water. Look at this. Her hemoglobin is at 6.8. That's about half of what it should be. Her red blood cells are tiny, and then here's the smoking gun. Her ferritin. That's her body's iron reserve tank. It's practically at 0. The tank is bone dry. This leads us to a crystal clear diagnosis: iron deficiency anemia. The best way to think about this is like iron is the essential fuel your body needs to build hemoglobin. And hemoglobin is like the little truck that delivers oxygen everywhere.
So no fuel, no trucks. No trucks, no oxygen. And no oxygen, well, that's why she feels so wiped out. Makes sense, right? So, this time, the diagnosis is pretty clear-cut. But that doesn't make the next question any less important. What do we do first? Choosing the right first move is everything. When you see a hemoglobin that low, your gut reaction might be to yell, "Get a blood transfusion, stat." But that's actually too much too soon for her. She's tired, yeah, but she's stable. Blood transfusions come with their own risks, so you save those for true emergencies when someone is actively unstable.
Okay, so no transfusion. What about IV iron? I mean, that's got to be faster, right? Well, yeah, but it's not the first choice. A huge rule in medicine is don't use a sledgehammer when a regular hammer will do. IV iron is for people who can't take iron pills or need their levels up super fast. You always start with the simplest, safest option that'll get the job done.
Which brings us to the right answer. We start with the absolute basics. Simple, oral iron pills. This will let her body safely and effectively rebuild its own iron stores and then its own red blood cells. It tackles the root problem head on. Simple, safe, effective. And with that, case number 2 is solved. Okay, so we just walked through 2 totally different medical mysteries. One was rare and complex, the other super common. But if you look closer, you'll see the exact same detective blueprint was used to solve both of them.
And this is it, the 4-step playbook for medical detective work. First, you've got to listen. Really listen. The story the patient tells you is where it all begins. Second, you gather the hard evidence, the objective clues from the physical exam and the lab tests. Third, and this is the art of it, you connect the dots to form a single, coherent picture. And finally, you target the root cause, not just the symptoms on the surface.
So you see, it doesn't matter if it's a super rare protein disease or a really common deficiency. The process, this way of thinking, is the key that turns confusion into clarity. We've cracked these 2 puzzles together, which it just makes you wonder, what's the next great medical mystery waiting to be solved? Thanks so much for putting on your detective hat with me today.